Thank you all for joining. Good afternoon. Welcome to the Translational Applications in Public Health lecture series. This is a collaboration between the Institute for Public Health and Medicine and the Northwestern University Clinical and Translational Sciences Institute. I'm Rich DeQuilla. I'm the director of the NUCATS Institute. I want to thank everyone for joining today. And before I introduce the speaker, I want to let everyone know that we will have time for questions and answers at the end of the presentation. There will be plenty of time remaining for that. Please use the Q&A function at the bottom of your Zoom screen. Do not use the chat button to submit questions, but if you submit through the Q&A function, we'll do our best to get to as many of them as we can at the end of the presentation. Today's presenter is Dr. Michael Ison. He's professor of infectious diseases and organ transplantation, as well as the director of the NUCATS Center for Clinical Research. He's also a member of Northwestern's Comprehensive Transplant Center and the Robert H. Lurie Comprehensive Cancer Center. Mike received his MD from the University of South Florida, did medicine residency at Oregon Health Sciences University, and then an ID fellowship and a master's at the University of Virginia. Thank you, Mike, for speaking to us today, and the floor is yours.
Great. Well, thank you very much for the invitation to talk with you today. This really was an exciting talk for me to put together because as someone who's focused his life on respiratory viruses, this allowed me to review some of the work that I've done, but also show how some of the work that we've been doing over the years has contributed to the endpoints we use for the studies that we have ongoing for COVID-19 and how we've leveraged our studies for other respiratory viruses to understand the epidemiology and impact of COVID-19. These are my disclosures. So what I hope to do is to talk first a little bit about some of the studies that we've been doing to define the epidemiology of respiratory viruses in hospitalized adults, with a focus on flu, RSV, and now adding COVID-19. I'll talk then about some studies that we've done on antiviral agents in hospitalized patients to show how our biggest gap was defining what the optimal endpoint for this. I'll then talk about how we participated in a BARDA, NIH, and CDC collaborative effort with academia to develop endpoints that led to the Ordinal Scale being proposed for flu studies, but then being applied for COVID-19, and then how we used all of this to build a COVID-19 BioBank to move forward. So I've shown the team. This is from a few years ago. We haven't updated the picture because we would all be masked. But really, I want to point out that this is a huge team effort, and I'll highlight some of the collaborators on many of these studies. So as we know, respiratory viruses, things like flu, RSV, rhinovirus, and seasonal coronaviruses are typically resulting in mild self-limited infections. They're more common in children, generally result in outpatient illness and clinic visits, and may result in complications. Most of these affect the respiratory tract, such as exacerbation of COPD or asthma, development of sinusitis and pneumonia, but they can also trigger exacerbation of non-respiratory illnesses. They're huge drivers for CHF exacerbations, heart attacks, strokes, and even things like triggering DKA or even poor control of their baseline diabetes. Most of these viruses follow a traditional seasonal pattern, and I showed you have two different slides that look at different viruses. You can see that flu and RSV really are predominantly occurring in the winter months, whereas rhinovirus, the cause of common colds, typically is outside that time period, typically in the spring and the fall. You have other pathogens like Parainfluenza virus, which tend to occur throughout the year and are less common in the winter seasons. And then coronavirus, seasonal coronaviruses, which tend to peak in the fall and early winter seasons. Collaborators here at Northwestern really helped define the importance of respiratory viruses among hospitalized patients with pneumonia. The EPIC trial, which was run at a number of different sites, including Northwestern, identified that respiratory viruses can cause both direct and indirect illness, and they're oftentimes most associated with clinical respiratory infections. In fact, for patients being admitted with pneumonia, viruses were actually more commonly identified as the cause of pneumonia than bacterial infections. It's important to note in most patients, even with very extensive testing, we didn't find a specific pathogen, probably because these are viruses or bacteria at relatively low concentrations. It's important to recognize that the virus that's detected in most of these patients is varied. Again, depending on the season of the year, we saw a lot of rhinovirus being detected outside the traditional flu season, with flu and RSV, as well as human metapneumovirus, being more commonly recognized in the winter flu season. So focusing first on influenza, it's important to recognize that this is outside of this year, where it's been generally non-existent, a significant contributor to clinic visits, illnesses, and hospitalizations. Year over year, there are differences in the epidemiology of when the peak incidence of disease occurs. We have some years where it's earlier in the beginning in December, other years where it's a little bit later, end of January. And then in pandemics, such as we saw in 2009, there's oftentimes an offsetting so that the seasonality doesn't reset for a year or two after the pandemic occurs. Influenza is a huge contributor of hospitalizations. On average, there are about 250,000 excess hospitalizations per year, resulting in about 35,000 excess deaths. Again, varying from season to season, and we do have some years where we've had significantly higher rates of hospitalization, such as in 2017-18, where we had just shy of a million individuals hospitalized and the highest rates of death, close to 100,000 individuals dying from influenza. Age is a major factor in terms of who gets sick. The majority of people that get influenza are those that are young and very old. But of those that are hospitalized, it's very unusual for individuals that are young to get hospitalized. The majority of these hospitalizations are occurring in the older adult. Changes occur when there's a pandemic where you have an inversion, so that the majority of infections typically are in the 20 to 50 year age group, and it takes nearly a decade to settle back into the traditional epidemiology. So the challenge that we identified nearly a decade ago is that respiratory viral pathogens are common in the hospitalized patient population. We were relatively unique in that we are very aggressive in sending testing, and so we generally have probably recognized the majority of individuals that are admitted to the hospital with most of these respiratory viruses. Nearly 92% of individuals with respiratory symptoms and about 80% of patients with other symptoms consistent with respiratory pathogens have gotten tested over the years. And with the implementation in 2009 of a multiplex PCR, we were able to look at a range of pathogens. So we established the NM respiratory viral cohort study, which hoped to define the epidemiology of respiratory viral infections in hospitalized adults, to understand the impact of antivirals when they existed for respiratory viruses in adult hospitalized patients, and to develop a data set for modeling for future studies. The way that we did this is we started by doing an EDW data pool where we collected some key clinical data that could be pulled easily from the medical record, and to identify those patients with the the infections, but we had to supplement this with primary chart review. We wanted to understand what were the symptoms that the patients were presenting with and some details behind decision-making in terms of therapies. And this is where having summer students really was a huge benefit. I've had AOSC students from Northwestern, as well as undergraduate and medical students from around the country that have participated in these studies, and I'll show all of their names in a few minutes. We started by doing targeted studies. The first study was on flu, looking at the first 5 years worth of data. The next year we did RSV. We added a year because it was a year later. And the third year we did parainfluenza virus, again, adding to 7 years worth of data. When we started submitting these manuscripts, we got a lot of requests by reviewers to say, how does RSV compare to flu, or how does parainfluenza virus compare to flu? And so what we did is create a catch-up protocol that we're almost done collecting data on for a total of 10 years of all of the respiratory viruses, so that we have a comprehensive assessment of the impact of these viruses. This will allow us to collect data on all the viruses, but more importantly, over the years, we've identified different ways to collect information, things that we missed early on, and allowed us to catch up with this. So the first project that we did, led by Jeremy Katzen, an internal medicine resident, now pulmonary fellow with a strong interest in influenza, was to look at 5 years worth of influenza seasonal data. And the reason why this is an addition to the literature is most studies looked at 1 to 2 seasons and didn't look across a range of seasons. This is important because years that have H3N2 predominating are more likely to be associated with severe illness. Seasons with a high burden of influenza B tend to have a lower degree of severity of illness. And so really being able to capture years like 2012, 2013, where the majority of patients had H3N2, we could look at seasonal variation in terms of the outcomes of these patients. What we found is that in most years, the majority of admitted patients with flu were women. About 40% of patients were overweight. The majority had underlying medical conditions, with about 20% of our patients being immunocompromised in one way or another. Looking at time from symptom onset to admission, a very small subset, only about a third of patients are presenting within the first 48 hours, the kind of classic time period that we think of for treating patients, with the majority of patients presenting beyond 72 hours after symptom onset. Not all of these patients present with fever. And in fact, in some years, the prevalence of fever was relatively low, about 35%. Hypoxemia was only seen in about a third of patients. Tachycardia and tachypnea were much more frequently seen. What we recognized early on is that since we had a small subset of patients that presented within 48 hours, and we can't really define when a patient comes to the hospital, that we would look at the outcomes of patients dependent on how well we as a healthcare system did in providing care for our patients. And so we defined empiric neuraminidase inhibitor therapy as patients who received therapy within 6 hours of admission. What we found is that people either were generally started on therapy either in the emergency room or on admission, or after their test came back positive, which was typically 12 to 24 hours after admission. What we found over the entire study period, with very little variability, about 83% of patients identified with influenza received neuraminidase inhibitor therapy at any time point, but only a quarter of those patients had empiric therapy. Factors associated with early onset of therapy was presence of diabetes, pregnancy, and those presenting with classic flu symptoms of fever or myalgia at presentation. Again, recognizing this is the minority of patients. Surprisingly, immunosuppressed patients were less likely to receive early neuraminidase inhibitor therapy, even though we have a standing protocol to empirically start it on all patients that have respiratory virus testing ordered. This may be because they have lower incidence of signs and symptoms. What we found is that earlier neuraminidase inhibitor therapy was associated with a shorter hospital length of stay. So you can see that there was about a halving of the length of stay in those patients who received the neuraminidase inhibitor early on after the admission from the hospital, and that mortality was lower in those patients that received early therapy. None of the patients who received therapy within the first 6 hours died, compared to about 4% with late therapy and 3.5% who never received neuraminidase inhibitor therapy. Small numbers, but an important observation. The second group of studies was focused on RSV, again, looking at 6 years worth of data. This included 642 patients. So again, a number, even though there was an additional year, very close to the number of cases for flu. Underlying lung disease was clearly the most prevalent condition in these patients, since RSV is a good trigger for exacerbation of underlying lung disease. We had about a 10 to 15% incidence of patients with immune compromising conditions with RSV. What we found very interesting is the dogma is that RSV alternates, where you have one season that's RSV-A alternating with Influenza B, and that you frequently don't have co-circulation of these viruses. But what we found in most years, you had relatively similar percentages of RSV-A and B circulating among our hospitalized patient population. We looked at presenting signs and symptoms and compared the non-immunocompromised with the immunocompromised patients. We had slightly lower presence of cough in the solid organ patients, much less upper respiratory symptoms, sore throat and rhinorrhea, slightly higher incidence of chills and lower incidence of fever in those patients that were immunocompromised. We don't have great therapies for RSV, and in fact, ribavirin, the only therapy that's used, is of questionable benefit, and because of toxicity, is generally only used in patients with underlying immune compromising conditions. We did find an overall rate of mortality of about 4.8% with RSV, consistent with existing literature. Lower rate of mortality in non-immunocompromised patients, but a relatively high rate in those with stem cell transplants, and particularly those that were actively receiving chemotherapy in the past 30 days. Sorry that these are a little bit blurry. The figures pulled from the publication didn't carry over very well. The third study that we did was Parainfluenza virus, again, over 7 years. We had about 500 patients that we included. A much higher proportion of patients were immunocompromised that had parainfluenza virus recognized, somewhere between 40 and 50%. Again, the majority of individuals having underlying medical conditions. In terms of epidemiology, classically, you see parainfluenza virus 3 occurring throughout the year, but we relatively consistently found higher rates during the summer months than in the winter months when the other parainfluenza viruses predominated. We saw an increasing trend to parainfluenza virus 3 over the study period, with stability in the number of cases of parainfluenza virus 1 and 2. Presenting symptoms were we had a cough in almost all patients, fever in about 60%, and sputum production in about 55%. There weren't any symptoms that really predominated with one of the subtypes of viruses over the other. Looking at outcomes, unfortunately, we had a relatively high rate of patients with severe disease. About 17% of the patients were severe enough to require ICU level care. A death occurred in 28% of these individuals. Again, more common in those patients that were immunocompromised. So from this overall set of studies, we documented that co-infections were rarely identified, a project that's been led by Hannah Nam, one of our fellows that finished last year. We have confirmed what has been now found in smaller studies in single seasons at centers throughout North America, that the incidence of invasive fungal infection complicating these infections is actually really infrequent as opposed to some of the data coming out of Europe. The biggest thing, and this is going to be a huge focus of some of the work that we're doing moving forward, is that there's really overuse of antibiotics in these patients. 86 to 98% of patients with these respiratory viruses were prescribed antibiotics on admission. If you look at our flu data, where we compared antibiotic use within 6 hours compared to neuraminidase inhibitor use, we had 26% of patients getting neuraminidase inhibitors within for the first 6 hours, where it was 89% received an antibiotic in the first 6 hours. And of greater concern, even though we identified only 7% of patients having a confirmed bacterial infection, 46% of patients were discharged on antibiotics, even though they had positive testing for respiratory viruses. And so this is an area where, not only from a stewardship perspective, but also probably for the better interest of our patients, we need to do better at minimizing antibiotic use in these patients. We identified morbidity is significant in these patients. We had a high rate of discharge to rehab or other enhanced care centers among those patients 65 and older, including patients that were homebound or home living prior to their admission for these respiratory viruses. And then one thing that was common is that there was a delay to identification for patients presenting with non-primary respiratory illnesses. So again, this has taken a huge amount of effort with a wide number of fellows, residents, and students that are listed here. I am super indebted to Anna Pawlowski at EDW. We've been working together since our first cohort collection, and every time we come up with a new thing, she's able to tweak the algorithms and get the data that we need. So let's change our attention to antivirals, what we know and what we've learned about these, and some of the challenges that we've identified. So for the most part, while it is now considered standard for patients admitted to the hospital with influenza to give them antiviral therapy, there really are very few trials that have prospectively studied antivirals in the hospitalized patient population. From the retrospective data, we can show that patients that receive early therapy within the first 48 hours after symptom onset achieve the greatest benefit, but there's benefit for patients at least through day 5, where there's a statistically significant benefit and a numerical benefit in terms of mortality and ICU need in those patients that receive therapy up to 11 days after symptom onset. Antiviral therapy is associated with a lower rate of progression to pneumonia, lower rate of ICU admission or death, really driving home how important it is to treat these patients early. There are a number of different agents that have been developed. The first study I worked on as a fellow was looking at the pharmacokinetics of oseltamivir in hospitalized patients. This is still the mainstay of our therapy for our hospitalized patients. During the pandemic, I helped lead the effort to get the Parainfluenza EUA issued, which it was, and to provide the data through clinical trials to support this both before the pandemic as well as the data that helped lead to licensure of this compound. We've been heavily involved with efforts for the newer classes of agents, those polymerase inhibitors, such as Baloxavir, which was approved 2 years ago for the treatment of influenza, and have really been focusing on trials of these therapies in the hospitalized patient population. One of the challenges that we had in terms of developing clinical trials in the hospitalized study, in a hospitalized setting, is that the FDA guidance was really vague because there weren't endpoints that could be reliably used. Basically, the FDA proposed placebo-controlled trials may be considered undesirable since oseltamivir had become the standard of care. That active control non-inferiority studies aren't possible because the comparator drug oseltamivir isn't licensed for treatment in hospitalized patients. Approaches would be randomized dose response trials or superiority add-on trials. The concern with this, which is what we learned with our Parainfluenza trials, is if you use two drugs with the same mechanism of action with the relative benefit in terms of the therapy, adding two together may not be very helpful. And in fact, that's what we showed. Patients that received oseltamivir versus oseltamivir plus either zanamivir or Parainfluenza really had no difference in outcomes. You would need a drug that would give you superior outcomes. The FDA listed a number of different potential endpoints, but these all have their challenges. The admission to the ICU happens in a relatively low proportion of patients, 15 to 20%, and particularly among patients being admitted to the hospital, a high percentage of those admitted to the ICU are admitted directly from the emergency room to the ICU. So it's hard to have a drug be able to prove a reduction in ICU level needs. Mortality is still relatively low, typically in the 1.5 to 3% range. So you need to have a study with about 1,000 patients to use as a mortality endpoint. Biomarkers such as temperature and vital signs are confounded by things like antipyretics and disease-modifying drugs. Length of hospitalization is quite a challenge because there's a range of indications for admitting patients. One approach that was used in several of the studies was time to clinical stability. So to the point where the vitals or other signals suggested that the patient was stable enough to be discharged and let out of the hospital. The other challenge is that some patients, particularly those that are immunocompromised, have altered clinical symptomatology and durations of illness. And so excluding them is oftentimes done for consistency of the data, but really leaves us with gaps in knowledge. So I was very lucky to be part of a process that led to trying to identify optimal endpoints of studies in hospitalized patients for flu. This led to a collaborative effort between BARDA, the biosafety group of the US government, CDC and NIH, as well as some academic partners to identify potential endpoints. The first trial that we looked at, first two trials that looked at endpoints were time to clinical resolution or time to vital sign stabilization, which were used in the IV Parainfluenza and IV zanamivir study. We then looked at things such as normalization of oxygen status in an ICU level study, our high titer plasma study, but none of these really had led to a notable difference in outcomes of patients, and this had us questioning, is this a failure of the endpoint to recognize the difference, or is it that it's very hard to overcome the impact of oseltamivir alone? So through a number of different efforts, looking at data that was collected through some of the studies that I just showed you, it was identified that coming up with an ordinal scale, which initially as it was defined had 5 mutually exclusive clinical outcomes measured daily from day 1 through 14, death, ICU with ventilation, ICU without ventilation, hospitalized with and without oxygen, and then discharged from the hospital with or without normal function, were the original ordinals that were selected. There was some work with FDA. They really didn't like the normal function since it was not rigidly collected. So we decided to move this into an effort to model this with existing databases. We also recognize that benchmarking people when they come in is critically important. Someone going to the ICU is clearly sicker than someone that's being admitted to the floor. And as a result, their time to recovery, their trajectory of illness is going to be a little bit different. So understanding how sick a person is on admission is critically important. So again, we looked around to see what scoring systems were available and what seemed to give signals for influenza. And a UK system called the National Early Warning Score was identified. This looks at respiratory rate, oxygen saturation, need for supplemental oxygen, temperature, systolic blood pressure, heart rate, and level of consciousness, and gives points for each of these different factors. These are easily accessible to clinicians readily. There's no specialized test or biomarker that needs to be utilized. So what we were asked to do is to provide our data from the NM studies that I had shared with you before to use in modeling with the group at BARDA. And what we found first is that we could identify populations of patients that were over a range of disease severity. Based on a new score of 1 to 3, those patients generally, even though they may have been admitted, probably could have been managed as an outpatient. New score 4 to 6 are people generally admitted to the floor, and new score greater than 6 are those patients that are much more severely ill and are oftentimes admitted either initially or during the first 48 hours to the ICU. What we found is that the demographics of most of these different groups were relatively similar. Not surprisingly, the average ordinal score went up with the different categories. The challenge, though, is if you try to design studies based on the ICU level population, as you can see from the end, you have a much lower number of individuals. And at the time, the cutoff for enrolling patients in studies was typically less than 42 hours after symptom onset. And that really takes you down to a relatively small subset of patients. So 31 out of the 700 patients that we had in our database would meet criteria for this enrollment. So this really helped us better understand what patient numbers would be available for modeling enrollment numbers, but also if we tweaked the enrollment criteria over time, how we could change the numbers. We then looked at the ordinal scale, and the way that we looked at this is visually. And again, I think you can very easily see comparing the panel on the right, which are patients that have a baseline new score of 4 to 6, versus the panel on the right, which is those that have a baseline ordinal scale of greater than 6. That you have a large proportion of those patients hospitalized, a much higher proportion of patients in the ICU by day 1, in the greater than 6, and that over time it takes longer for that blue bar, the discharged, to really become the predominant bar. There's a slight difference between the population presenting less than 72 hours versus greater than 72 hours. So again, allowing us to see how we would expect these populations to progress over the natural course of their clinical disease. We then did a much more complex model using time from symptom onset to initiation of neuraminidase inhibitor therapy. We knew from the literature that you had better outcomes in those started early than late. And we're able to actually demonstrate that quite clearly using the ordinal score. You were able to move more quickly to a discharge state in those patients with therapy started early than those that were started late. Unfortunately, one of the things that we found is that the day that there were statistically significant differences in the ordinal scale was variable by day. So you saw an early signal at day 4, as well as later signals after about a week of differences in outcomes based on time from symptom onset. Additionally, when we broke it down based on virus subtype, there are marked differences between season and virus type, in which days were statistically significant. Again, highlighting that the simplistic approach, which is what we've been using with COVID-19 as well, has some of its challenges, and there's been a push to add time to this analysis to really strengthen the ordinal scale. So we have moved into an era where newer drugs have come down the pike. Baloxavir is the first of these to be approved for treatment of patients with influenza A or influenza B. They're active against resistant viruses, and so really are a great potential therapy. Additionally, they really drop the viral load much more quickly than oseltamivir or the other neuraminidase inhibitors. At 1 day, you have about a half a log reduction in the virus with oseltamivir versus a 3.5 log reduction with baloxavir. So presumably in a population such as hospitalized patients, you would see much greater benefit with the use of this more potent antiviral. So we started looking at this in a large study called Capstone 2. This looked at patients that were presenting within 48 hours after symptom onset, confirmed with influenza, that had conditions putting them at high risk for flu complications. Underlying medical conditions, pregnancy, immune compromise, obesity, all were eligibility criteria. We were very lucky in this study because the year that we enrolled patients, which was the first time that this had happened in decades of flu research, about half the patients enrolled had influenza A, H3N2, and half the patients had influenza B. So we could look at the relative benefit of therapy across the different subtypes. As you can see for influenza A, both the oseltamivir and the Baloxavir had improved clinical recovery and virologic recovery, whereas patients with influenza B, the blue line, which is the oseltamivir, was superimposed on the green line, which is placebo, whereas you retain the benefit of Baloxavir against influenza B, both clinically and in terms of virology. So this is important. We knew that oseltamivir wasn't as good of a drug for influenza B. So again, highlights that perhaps for influenza B, this therapy is the preferred regimen for these patients. But I think what was a big surprise to all of us, despite a much greater reduction in viral load, you really saw no significant clinical benefit. And this was seen in the phase 2 studies as well. So this really had a lot of us scratching our heads. Where we thought we would see a difference is in the FLAGSTONE study. This is a study that looked at patients admitted to the hospital, and they were randomized to either receive placebo plus standard of care neuraminidase inhibitor, which in general was oseltamivir, or the combination of baloxavir plus standard of care neuraminidase inhibitor. And what we did, and I'll show you the box plots on the next slide, is as our endpoint for this trial, we used the Ordinal Scale. Well, no matter how you analyze, whether it's recovery, discharge, mortality, or the Ordinal Scale, which I'm showing you here, there was really no improvement in clinical outcomes with the addition of baloxavir to neuraminidase inhibitors, despite the fact, as you can see from the virology on this inset figure, that baloxavir patients really had a significant rapid decline in viral titers, both by culture and PCR. And again, looking at these box plots of the Ordinal Scale over time, they really don't look terribly different. You have some baseline differences in the population, but the combination therapy really had a slight trend in those patients in the ICU to being out of the ICU quicker, otherwise no significant benefit. So this is the first time that we used the Ordinal Scale, and it did perform and correlate well with all of the other endpoints that we looked at, again confirming that this is probably a reasonable measure. Again, needs to be optimized, probably including the use of time into the mix. So the Ordinal Scale was adopted by WHO very early on and was recommended as the endpoint of choice for COVID-19 trials. It was first used in the lopinavir-ritonavir trial, where there was no significant difference in clinical recovery between lopinavir and ritonavir, and several studies have gone on to confirm this lack of activity. It was used for the ACT trial that led to the approval of remdesivir. Again, I think the advantage of this is you can look at subsets of patients, which you can see in these Kaplan-Meier curves, but actually the curves that are deeply hidden in the supplemental figures are the box plots. And again, I really like the way that John pulled these figures together, where you can really see, particularly in the ordinal 4, 5, and 6, that there is a clearer and more rapid trajectory to these patients transitioning to an outpatient and improved status over time, whereas once you get into those patients that were more severely ill, there was much less benefit that was seen. So the next thing and the last topic that I'll talk about is some of the work that we have done. We are very interested in resistance emergence in influenza. There are two types of resistance that can emerge: primary infection with a resistant variant, uncommon, although it did become common in 2009 before the pandemic, and then treatment emergent resistance, where particularly in immunocompromised patients, the virus is susceptible at the beginning of therapy and then develops resistance. The mechanism and frequency is different to adamantanes, which we don't use anymore. Resistance emerged in about 40% of patients by the end of therapy and now is broadly present in all circulating strains. Neuraminidase inhibitors develop in about 1% of patients at the end of therapy, whereas polymerase inhibitors have a higher rate of resistance emergence at the end of therapy, with about a 10% incidence in adults, 25% in kids. So in one of the first patients that we saw in 2009 during the H1N1 pandemic was a 35-year-old gentleman that had undergone auto stem cell transplant for refractory cryoglobulinemia. He was admitted early after the transplant for plasmapheresis, and then presented a few days later with a 2-day history of fever, cough, with sputum production, started on antibiotics, and found to have no disease. He had a respiratory viral panel which presented with non-typable influenza A. This is how it came up for the pandemic virus. We started him on oseltamivir, and he had improvement in his fever and clinical recovery. This was continued for 10 days and then discontinued because it felt that he had received enough therapy and had improved. Unfortunately, several days later, he had fever again and had a negative nasal swab, but positive BAL for influenza. We used a higher dose of oseltamivir, hoping to get him off of to treat any treatment emergent resistance. Unfortunately, despite that, he had some initial improvement, then worsening of fever, got bronched, which again was positive despite a negative nasal swab, and sent that off to CDC. While we were waiting, we switched him to IVs and Antivirals, and then added ribavirin when we got confirmatory testing showing that he had developed H275Y mutation induced by the therapy that he had received. Based in part on this case, we developed the Northwestern Respiratory Viral Genomic Study to look serially at the mutations that develop in immunocompromised patients with flu and RSV in response to therapy, and then added on a study led by Han and Am to correlate point mutations in RSV from hospitalized adults with clinical outcomes, and then collect serologic responses based on the interest of collaborators at the University of Washington on how serologic responses changed in these patients over the course of their illness. This study collected blood and viral samples on regular basis from all individuals. Viral samples were collected from nasal swab every 4 days, and if a BAL was performed, blood was collected once every 8 days. EDW data was used to collect clinical outcomes data. Sequencing initially was done at the University of Washington group, and then when we had the expertise here for RSV, we started switching all of our sequencing here to Northwestern. We've sequenced 9 patients. 2 have developed resistant variants over time and have almost completed sequencing of 239 hospitalized RSV patients. Antibody testing is being done by our colleagues at the University of Washington. And we have plans to expand this to a multi-center study involving all of the transplant centers here in the Midwest. We were able to use this and flip it immediately into a study for COVID-19 thanks to a number of different levels of support. We got support from NUCATS to develop the SARS-CoV-2 BioBank, and I'll show you some data for the last 5 minutes on this. We got money from the Lurie Cancer Center to support the convalescent biobank. Chad Achenbach really spearheaded a lot of the effort to pull the clinical data through the EDW. And then Sage Altana and I have been developing a Midwest-wide COVID-19 transplant cohort study, all of which is using things like REDCap and EDW to support them. So the Northwestern SARS-CoV BioBank study has enrolled 58 patients to date. You can see the therapies that they had received. These were collected in the first wave of the pandemic. We had 18% of patients being Hispanic. BMIs were relatively heavy and a very frequent presence of comorbid conditions. Here you can see some of the preliminary data from the study with the information color-coded throughout all of these in a similar way. Those patients in light blue being the patients that were discharged without ever needing the ICU. Purple are those patients that were discharged that were in the ICU at one point or another, and red, those patients that were ended up dying. The figure on the left shows you what samples were collected when. The open triangle represents when they either died or were discharged from the hospital. Clearly, we had an older population with skewing, particularly in the male side of things, to patients that were older than symptom onset. Presenting signs and symptoms were as would be predicted, and underlying medical conditions, again, very reflective of what we have seen system-wide with hypertension, renal disease, and cardiovascular disease being the most prevalent. In terms of the outcomes for these patients, the heavier the patient was, the more likely they were to end up and spend time in the ICU for these patients. We've looked very carefully at a number of different scoring systems. The deterioration index, which is available as part of EPIC, appears to have the best predictor of outcome with a relatively clear threshold of 50. Those patients that remain under 50 are unlikely to require ICU level care, whereas if they have levels above 50, they're more likely to need ICU care. And if those numbers persistently increase over time, they're likely to die. The NEWS score, or the MUSE score as it's called in EPIC, performed similarly, but because of a narrower bandwidth was less effective in predicting outcomes. And we confirmed that the 4C mortality score, which looks at a number of different factors on admission, truly was predictive of disease severity, as it's been confirmed in the UK data set. We've sequenced these viruses. Again, most of the viruses that we identified were the initial B1 virus with a few other subtypes, including the Chicago strain that we identified earlier in the clinical illness. We also looked at serial quantitative virology and found that the patients did have prolonged viral shedding in these patients, particularly those that are very ill. I've marked on here the vertical line is day 10, so you can see most of these patients had detectable virus at day 10, and that most of them were detectable below that purple line, which is where we would predict them to have culturable viruses. This is important because you can see in those patients in the ICU, they tend to have persistent high-level viremia despite being 20 or plus days after their infection. So I really want to thank the amazing collaborators on this, Egan Ozer, Judd Hultquist, Lacey Simmons, and Ramon Lorenzo Redondo. I want to thank the coordinators, Meg Gibson and Sarah Kinch. They came in when everyone was still scared about COVID-19 and collected the samples from the sites. And then Jack and Tanisha, which are continuing the effort moving forward. I'm not going to go through the details. The data is just starting to come out, but we've also pulled together a convalescent biobank, which includes now 6 of our lung transplant patients. And we're really starting to see some interesting signatures coming out of patients that are recovered from COVID-19. So it's been a real honor talking with you today. Hopefully I've given you some interesting things to think about and to see how taking an existing program can really leverage our capacity to respond to pandemics. Thank you.
Thank you, Mike. That was great. And we have some questions about both flu and COVID. So Dr. Masters asks, can you provide any insight as to why so many patients who are believed to have a viral infection that is difficult to diagnose, but nevertheless are believed to have a viral infection, why are they discharged on antibiotics?
Yeah, I think that's one of the critical questions that we need to think about. I will say it is not surprising because if you look at ambulatory patients, those that aren't even admitted to the hospital, we see a very similar high frequency of antibiotic use. I think part of this is that in most clinicians' mind, particularly when they see an infiltrate on the chest x-ray, they think bacteria. And again, I think this has been shown with the EPIC trial and even some of the work that's been done here and in other locations, that the frequency of proven bacterial superinfections is pretty low in these patients. And one of the studies that I think would be very interesting is a trial of early versus standard of care stopping of antibiotics, because it is possible that a lot of these patients that are being admitted to the hospital have bacterial overgrowth in the lung and may benefit from a short course of therapy, but that short course may be a day or two while you're waiting for the testing to come back. And as we've seen in other areas, shorter courses of antibiotics, even for hospital-acquired and community-acquired pneumonia, has been shown to be very effective. So really, I think an area that we need to pay attention to. I think we need to really look very carefully at doing studies of our providers as well to understand what's driving them to choose to start antivirals early versus late, and what's driving them to continue the antibiotics, because that will help us understand how to change behavior. I will say most of the data that we have collected is in the era when we had our standard RVP that was run 1 to 2 times a day, and there was a relatively significant delay between sending the test and getting the results, which I think was responsible for a lot of the delay, since the majority of people waited until they had a positive test before starting. Now that we've gotten more rapid testing, particularly that's done in the emergency room, we've definitely seen a significant increase in the proportion of patients getting treated very early on, but we haven't seen a change in the antibiotic utilization despite that.
Dr. Kociolik asks an interesting question. After seeing no RSV or flu in the Southern Hemisphere in the winter, Australia saw a summer surge of RSV when they opened up, but not of flu. And he observes that here at Lurie, they're starting to see upticks in RSV. Well, I guess this is in the US, not just at Lurie, but not flu. Any thoughts why RSV would adapt better to a summer peak over flu?
Yeah, so it may very well be a complex set of dynamics. I think kids are, for much of the country, are just starting to go back to school. Adults, we're moving outside of the traditional flu season pretty quickly. It'll be interesting to see as people have gone to Florida and whatnot, do we see some cases of flu being introduced? I think what we're going to have to do is people are trying to draw a lot of attentions over what we see this year. I think what will be far more interesting is what happens next year. There is some concern that there may be a very high rate of flu in the community because maybe people didn't get the flu shot as well and have waned their immunity through lack of exposure. There is a concern that one of the flu types may die out, and so because the low circulation, perhaps H1 or H3 will not circulate anymore moving forward. And if that were the case, if it's H3 that dies out, that's good because there'll be less severe disease. And then if this persists next year, will probably in part be because people continue doing things like masking and hand hygiene. I think one of the things that is underappreciated is the importance of kids not going to school, playing in a lot of this. And I do suspect as we see more and more kids going back to school, we'll see more and more infections as we're seeing now.
Here's another question. What about the microbiome targeted by the virus in the olfactory epithelium or the tongue?
So we haven't looked at that. I will say in part because of one of the program officer's comments, we are going to be significantly focusing on a grant proposal that we're putting in September at the nasal microbiome and the nasal mucosal responses to infection. So I don't have a good answer for you from our data yet, but that's definitely something that we plan to incorporate moving forward.
So since respiratory viruses are so common in pediatrics, did you look at whether the adult patients in your study with flu, RSV, or paraflu had children as close contacts?
Yeah, I think that's a critically important question. This was a retrospective study, and so we were going back oftentimes years after the patient was admitted. As we all know, the documentation, particularly of whether or not there's kids at home in the adult medical record, is relatively hodgepodge. Some people will list it, some people will not. So it was one of those factors that we did try to look for, but it was so inconsistently documented, I don't think I would trust the data that we have pulled.
I have quite a few questions of my own, but I'm only going to pick one because of time. The Infectious Disease Society of America guidelines for use of monoclonal antibodies in COVID-19 pre-hospitalization in non-hospitalized patients has been changing. Could you comment on what the latest update is, particularly around the cocktails of these antibodies?
Yeah, that's a great question. So there's one of the big challenges is that there is, as people have recognized, there's more and more variants that are out in circulation. The susceptibility of those variants to the different drugs has changed. So in the United States, for example, because of the rapid spread of the California variant and the UK variant, which bamlanivimab has a lower level of activity, the US government is no longer distributing just bamlanivimab as a monotherapy, and it's been recommended not to use it as a monotherapy. And so I think we are in the process of adapting that to use the combination of bamlanivimab and atezolizumab for treatment of our patients here at Northwestern. We do have a relatively small batch of the Regeneron combination that we are retaining because it seems to retain activity against most, but not all of the variants. And so if we see a significant increase of the relevant variants come into the area where the BAM-EDI combo wouldn't be effective, we will switch over to the combination therapy. Even in the clinical trials, there was a lower rate of resistant variant emergence with the use of combination therapy. And there have already been, particularly in immunocompromised patients, identification of these variants coming up with therapy. We have ourselves identified such a patient, very immunosuppressed patient here that developed a resistant variant after receiving monoclonal antibodies. So again, highlighting the fact that this is something that probably is going to be in the best interest of our patients.
I'll ask you to expand on that a little more. Are you comfortable using it in the higher risk populations for which it's indicated?
Yeah, I think, and you look at the data that Tina Stoser has generated and has just been accepted in clinical infectious disease, looking at our data, that the high-risk patient population, and a sizable percentage of those patients were immunosuppressed patients here at Northwestern, had a significant reduction in need for hospitalization or ER visits. We had about an 8% incidence in patients that received bamlanivimab compared to about a 20% incidence in those patients that were recommended to get it but didn't, for whatever reason, receive the therapy. And so, that really does suggest that there's a significant benefit. And I think particularly in those high-risk patients, it does provide benefit. The critical caveat to that is getting the patients in early. These drugs, although the EUA allows for its use up through 10 days after symptom onset, really the data shows the earlier you get the therapy on board, the better.
Well, thank you very much, Mike. It was a very informative presentation, and thanks for everybody who attended.
Thank you.
Bye-bye.